Good morning. We're going to start into chapter 15.3, pages 536 to 567 in your book. And we're going to get through a list of gynecological procedures. Now this is not a complete list. This is a list of the common procedures. There's many procedures. These are some of the ones that you're probably going to encounter in your clinical rotation. Some are diagnostic. Some are procedures that may be combined with other procedures, so you may see more than one at a time. Laparoscopic resection of an unruptured tubal pregnancy or an ectopic pregnancy is something we showed videos of in class. So these cases may be done laparoscopically. If they rupture, they're going to be done emergently. Same laparoscopic equipment that we use for most other laparoscopic procedures. As it says there, position will be lithotomy with Trendelenburg. Sometimes laparotomy and lithotomy combined. When it does turn into a ruptured, like I said, it's an emergency. It's a emergency laparotomy. It's an incision in the belly, and there's going to be a lot of blood. So a lot of suction, sponges, people need to move fast. It's sometimes hard to keep your cool, but you need to try to keep your cool and just try to do as much as you can with as little time as you can. It'll be chaotic, it'll be mayhem, it'll be very crazy procedure. Some of the signs and symptoms and basically indications for some of these procedures for GYN are on there. And some of these procedures are actually diagnostic tests, such as hysteroscopy. Procedures of the vulva and more. Some of the other procedures, cervical biopsy, marsupialization. Some of these we're going to get into in more detail later in the presentation. More procedures. The first 5 on this slide are mostly prolapse repairs, where we're trying to fix something that's prolapsing into the vagina. So we need to do some type of repair to tent that back up and make that canal normal again. Cervical biopsy. Cervical biopsy, we're not going to dilate the cervix if we're going to do a cervical biopsy, for obvious reasons. The cervix, you don't want to mess with that specimen that you're trying to get out. And when you use Lugol's, Lugol's has iodine in it, as we talked about in class, and iodine is going to stain all the tissue that is normal. The abnormal tissue is not going to stain, so then they know which tissue to take out. The acetic acid is going to stain the abnormal tissue white, so they know to take the white tissue out. It's kind of like when you put hydrogen peroxide on a fresh cut that starts to bubble up and turn white. That's what's going to happen on the cervix, and they're going to take that part out. Cervical cone leap procedure is a loop type cautery where they're just burning out kind of a chunk of that cervix that's going to become a pathology specimen. DNC vacuum and D&E are done for many indications. We'll get into those a little bit later. C-section we've already talked about. Hysteroscopy, like I said, is a diagnostic test and an intervention, and often leads into a D&C or maybe another procedure that's larger, a hysterectomy, etc. Fallopian tubes and ovaries, ectopics, sterilization, occlusion and torsion of the tubes, torsion of the ovaries. Tuboplasty, we're repairing those tubes due to adhesions or some type of occlusion into the tube. And we talked about a hysterosalpingogram for looking at those tubes to see where that occlusion is so they know how to fix that. The abdominal incisions we went over in class, they are done transverse, not only for cosmetic reasons, but they are much stronger in repair. You can compromise nerves, but they are much, much stronger for a repair and look a lot better. You can still wear a bikini. Now remember, in these procedures, a lot of these procedures are lithotomy and laparotomy or laparotomy, sometimes a combination of both. And thing to keep in mind with these is laparotomy is going to be a clean procedure, laparoscopy is going to be a clean procedure. When you go into the lithotomy parts of the procedures, when you're going through the vaginal canal, that is not clean. That's a clean, contaminated class 2 wound. Use of the uterine manipulator was on page 547 in your book. Again, class 2. It's going to be dirty. Hysteroscopy, as I said earlier, can be diagnostic. And basically in a hysteroscopy, we're going in to check out what's going on inside that uterus. And then they'll say we're going to proceed as indicated, meaning they're going to proceed by what they see inside that uterus. Instrument setup very similar to a D&C, but you're going to use a scope. Some useful weapons for distending the uterus, listed on the slide there. Marsupialization of a Bartholin's gland cyst. Now these, as we talked about in class, can be infected. So on that note, we may want to culture that, find out what's causing the infection. A big component of this is the entire cyst needs to be removed and the cavity left open so it can heal. If the cyst is not completely removed, then it has a very high chance of recurring. And that's going to be a class 3, class 4 due to the dirty, infected nature of that cyst. Bulbectomies are done for recurrent infections. There's several indications for it. Pay attention to your anatomy so you know what we're doing when we do a bulbectomy. Ablation of condylomata or external genitalia warts is similar to a bulbectomy. Often they laser these warts off. Very important to remember, as we are lasering these warts off, the plume from the evacuation can transmit. You can breathe in this stuff and be getting this stuff in your throat, in your mouth, in your nares. You got to be very careful with the plume from these lasers. You don't want to be breathing that stuff in. D&C has many indications. A lot of times it's abnormal bleeding that brings people to the operating room for this, and we want to try to refresh that uterus and give it a new lining. You're just kind of cleaning out the lining of the uterus, give it a nice fresh new lining, kind of like hitting the refresh button on your browser. Starts it all over again. We went through the steps in class of a D&C. Here's a little reminder for you to kind of get it into your head how that procedure is going to go. You're going to see a lot of these when you're in clinical. Oftentimes they'll do several of these in a day. Cervical biopsies may be done in the office. You may see them in the operating room. Titular biopsy forceps is that pistol grip forceps that looks kind of half like a rongeur and half like a tenaculum. And it grabs hold and takes a bite out of that cervix, and then we're going to send that off and get a specimen from that. I covered the acetic acid and Lugol's to identify abnormal tissue. And remember, when we send off a pathology specimen, you want to be very careful handling those specimens. It's important to take good care of the specimen and not contaminate it. It could change how you treat somebody if the specimen is not handled properly. Salpingectomy is performed for occlusive disease, ectopic pregnancy, infections, tumors. Basically, we're taking out the tube. I skipped the oophorectomy. Oophorectomy is also something we do mainly for ovarian cancer. They'll get a serum CA-125 titer, and if it shows up cancer, we're going to take that ovary out. Moving on to endometrial ablation. These are, and again, chronic bleeding, something we got to treat. They'll laser out the endometrial lining of the uterus. It's going to do some scarring, but it's going to hopefully bring that bleeding under control. The balloon ablations you're going to probably see in clinical, those are kind of icky procedures, I think. They're filling a balloon and then they heat it up for a period of time, and often patients that are asleep will start moving from this because they can feel that. That's 86 degrees Celsius is pretty warm, and especially for 10 minutes. Myomectomy is uterine fibroids or myomas. These will be pathology specimens. Again, take good care in handling these. They want to find out what that thing is. Often they're benign, but once in a great while they'll find one that's it's a bad tumor, and it's got a metastatic component to it. They want to take care so that's not going to spread any further than it already has. Adhesions can be problems in these types of procedures. So like the slide says, they're going to try to do things to minimize adhesion formation. Talc on your gloves can really cause adhesions. Low molecular weight solutions and heparinized solutions help keep these adhesions from forming. Left you some charts for those of you that like anatomy. Can kind of go over that and make sure you understand the anatomy. It'll help you understand the procedures better. Thank you. We'll have a new video coming soon.